Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
I'm excited to introduce Dr. Dellon, retired professor of plastic and neurosurgery at Johns Hopkins, and this is part 2 of our chat that we started in last week's episode. In this week's episode, we talk about Morton's entrapment, some very interesting things regarding his observations of neurogenic heel pain, and we talk more about his book, The Prosector, which is a great novel that he just wrote and released in the last year. And I hope you enjoy our chat as we complete this great conversation. And if you haven't listened to the first part, I would recommend that you go back to that, listen to it now, and then come back to this episode. You'll get that much more out of it. So without any further introduction to this episode, Dr. Dellon. So anytime you develop something new concept, new procedure, there's always going to be pushback. What's one of the, sometimes it's fun to look back at things after a period of time, because at the time that it happens, you go, damn, that shouldn't have happened. These guys are clueless or whatever. But then after a decade or 2 or 3, you can almost kind of laugh about it. Is there one episode of pushback that, that comes to mind where it's like, now it's pretty funny, but at that time it wasn't?
Well, in terms of the neuropathy you're asking?
Or any of the things that you've done. I mean, because let's face it, you've kind of put the peripheral nerve world on the map. And the reason you've done that is there's multiple factors, but one is that you've made discoveries and observations that those phenomena were there for centuries before, but nobody observed it. Nobody took that and then clinically extrapolated it. And like in your book, where they take a clinical problem and go into the anatomy lab. And I think, when you talked about the groin pain patient, that's what Olivia did in her book, or in the book, was go to the lab. Where's that other nerve that I missed? Because this poor patient still had pain after was it the iliofemoral or genitofemoral nerve? And she didn't know about the iliohypogastric. I mean,
you got it. Yeah, she knew about the ilioinguinal, but not the iliohypogastric. And they're both near each other. They come from the same place in the spinal cord, but they're about an inch apart down in the region of the groin. And usually the surgery gets both of them involved in scarring. And if you only remove one of them, the people really don't get better from the nerve surgery that's done. So you have to do both. And we published that, our clinical results in the year 2000 about that. But what you asked was all these problems that happened to me, which in hindsight were horrible, and which Olivia faces in the book.
Right.
I identified that wrist pain could be due to nerves to the wrist joint, and that in this part of the hand, as Olivia finds, there's there it is, the dorsal here. I can do it. All that was known was that there was one nerve here, the radial sensory nerve, and if you only operated on that, no one would get better. And she found the second nerve, the lateral antebrachial, so that there are really 2 nerves here, just the way there are 2 nerves in the groin. Well, when I found that, and so I would begin to get patients that my teachers had operated on, and the patients weren't better. and I would fix their wrist pain and fix their dorsal radial pain. And I wound up becoming attacked by my own teachers. And I have Olivia living through that same thing when it happens to her. And you can read about that in the book. And the same way the doctor came down to the laboratory and evaluated the Dr. Kornblath, David Kornblath. He did a great job evaluating diabetes in these monkeys. He nevertheless worked against me at Johns Hopkins and he wrote a paper that was co-authored with several other prominent people around the country, which you said originally. He said that I tell everybody that you should operate on diabetics with peripheral neuropathy, which I don't. I say you should operate on people with peripheral neuropathy who have a superimposed nerve compression. I wish we could say it in fewer words.
Right.
But diabetes is their comorbidity. It's their underlying problem. It's like people have cancer and are treated with chemotherapy and then have neuropathy because of the drug. We operate on their nerves and decompress them for chemotherapy, neuropathy. It has nothing to do with the original cancer. They either still have cancer or they're cured of cancer when we operate on them. The diabetics are still diabetics. Mm-hmm. They still have a neuropathy, however you'd like to define that, but their symptoms can be greatly improved, if not completely improved, by decompressing nerves. So these things that happened to me that I remember that were horrible at that time and they're still horrible in retrospect because I put them in the book, all have to do with education and I think are very understandable in hindsight today.
Now, has any of those critics ever come back and said, hey, you know what? You were right. I mean, that takes it takes a really big person to be able to do that.
Well, as you can see in the book, and I won't spoil it for you, you'll see what happens when she's investigated at her university. And that's what happened to me. And actually, about 6 months ago, one of my main critics in neurology, who has since retired, wrote me a note and said he's come to realize that I was correct in the things that I'm saying. He won't go public and say it, but in private, he wrote me an email. I guess now it's sort of public because I put it into your podcast, but I won't say who did apologize.
No, we don't need to say that. I'll give you an example. I'll give you an example, not from my institution.
There's another very famous Midwestern university with a great plastic surgery department where a neurologist on the faculty said that and I'll use the pronoun where you can't tell if it's a man or a woman. The neurologist on the faculty said over their dead body would a diabetic ever have a nerve decompressed in their university hospital in the lower extremity. Over their dead body. I mean, That's a pretty strong feeling.
I guess maybe you just need to see if once they did get their dead body because it was done, were they going to donate their body to science so that further study of the nerves could be done? But so, you know, it's real interesting. I had a gentleman on a while back, Gary Reinl, who talked about the RICE protocol, rest, ice, compression, elevation, it's so deep and entrenched. Everybody in every specialty to almost every person. And as he pointed out, almost every soccer mom knows about there's an entry, pack it in ice, elevate it, compress it. You know, that's what you do. Now, the guy who came up with that was a guy named Dr. Merkin, Gabe Merkin. And Merkin said he just kind of made that up, but the science really wasn't there. But Merkin's retired now, but he was from Harvard, to my understanding. And he came out and he said, I was totally wrong on that. And in fact, he wrote the preface for this gentleman, Gary Reinl's book about coming out of the ice age, about how we might really want to think about ice, and basically came out and said, you know, I was not correct. Science has, you know, proven what I said was not true. And to me, that is really, I mean, I identify with somebody that can be that humble and honest and say, you know what, I was wrong at that point in time. I think that takes a lot of pressure off of a lot of people if they can just say, you know what, I was wrong at that time, but now here's the science and I get it.
Yeah.
But
going forward, I've come to grips with the fact that where I should be going is not trying to change a few totally entrenched critics, many in podiatry whom you know, but rather to try to educate the public. It was difficult for me when I was still an active surgeon. As you know, I retired March 6th of last year. When I was a surgeon trying to educate the public, it looked like I was being a salesman trying to sell surgery, and they should come to me because, of course, I earned my living operating. But I'm retired now. I'm not earning any money operating on anyone. I'm just trying to educate the public. And I think that's the way to go. The public will go to their doctors. And I've had the wonderful fortune to work overseas in Europe and teach. People outside of America are much more open to this concept of operating on nerves and diabetics than they are in America.
Why do you think that's the case?
I think neurology has almost a stranglehold over the criteria for surgery, reimbursements for surgery. There was a time about maybe 20 years ago, Medicare refused to pay for a hand surgeon to operate on carpal tunnel unless there was an electrical test that proved that's what they really had. They subsequently modified it and let us operate if the patient wore a splint for 3 months, if they had a Tinel sign, and we had made a certain clinical measurements. But after about 5 years, they looked at all the data and they said the doctors were not over-operating on people and they no longer required electrical testing. The standard of care for diabetics used to be every diabetic needed an electrical test each year, and neurologists make between $1,500 and $3,000 doing these complicated tests. Now the standard of care for the American Diabetes Association is diabetics should have one test in their lifetime to show that they have an underlying neuropathy. So the neurologists, little by little, are having to release this hold they've had on allowing a surgeon to make a decision with their patient when they can and when they can't do their surgery.
Well, I guess you could say, the silver lining type of, perspective is at least all of this academic PTSD from what you had endured gave the genesis of a great story in your book.
Yeah.
and I love the fact in the book you talk about, you didn't name it here on the chat we're doing now, about what you call that test where you go in and tickle the bottom of their foot. And I thought that was one of the best things I ever learned from you. And trust me, I've learned so much from you. And I'm endeared to you forever for all of that. But I think, you need to tell the audience the name of that test because it's really important and they'll remember it.
Well, when I have a patient, let's say it's a man and I've operated on them and I bring his wife in to see him in the recovery room, I said, now tonight when I call you at home, I'm going to ask you to put your fingers down inside the bandage and tickle the bottom of his foot. Do it pretty hard and see if he laughs. And I tell them this, and the residents are with me too. And I say, now, this is a new medical examination technique. We've given it a name. When you try to see if sensations come back by putting your fingers in the bandage and rubbing them on the bottom of the foot. I said, well, what do you call that test? I say, well, we call it the test tickle. So if I call you tonight and say, I want you to give your husband the test tickle, you'll know what I'm talking about.
Yeah.
And you actually can go to YouTube and type in Dellon and test tickle, and you'll see me doing this on a patient with them laughing in the recovery room.
Oh, that's great. Great stuff. Well, we've kind of hit the diabetic peripheral neuropathy and superimposed nerve compressions. And I thought it'd really be great for the audience for us to talk a little bit about neurogenic heel pain. And, I think the paradigm is shifting now a little bit, at least with diagnostic ultrasound being implemented more routinely now in patients' workup that come in with heel pain. And although the literature tells you almost everything is plantar fascia as the pain generator, we'll know very quickly within 30 seconds after looking at them with an ultrasound that their plantar fascia is or is not affected. I mean, very objective. And if it's not, then seems to be something usually going on with the medial calcaneal nerve or nerves. And you published a paper about 2003 the different anatomy of the medial calcaneal nerve branches. And that, again, no one talked about a specific anatomical tunnel for that nerve or nerve branches. And we've seen that numerous times in the lab. So you want to talk about neurogenic heel pain a little bit, because I think it's really interesting. We can talk about the study by Rose and Millay, where they looked at all the people that came in with this perceived diagnosis of plantar fasciitis, which I don't even use fasciitis that much anymore because we know it's more fasciopathy. But to get back to the thought on that is that they had, I forget, it was a pretty high percentage. I haven't looked at that paper for a long time, but it was like close to 70% of people that came in with heel pain had some multiple pain generation, with a segment of that being the nerve medial calcaneal.
Okay, so
first
of all, by history and going back to what I've learned from Podiatric Foot and Ankle Group, the real definition of plantar fascial problems is Latin, which is post-static dyskinesia. And so if the patient gets out of bed in the morning and their first step hurts because the plantar fascia, which is contracted at night, pulls on the calcaneus, which is a bone, they get pain. That's what we're talking about for plantar fascial pain. And that's in comparison to people who have heel pain, where they wake up in the morning and their heel doesn't hurt them. But during the day, worse and worse, they develop heel pain and numbness. So the history is really important. And like everything else, some people might have both. But as you said, if a patient walks in to a medical doctor's office and says, the front of my chest hurts, well, they're having a heart attack, And if you walk into a foot and ankle doctor's office and say, my heel hurts, you have plantar fasciitis. Mm-hmm. So one of the ways, and pain is something we have trouble measuring. But if the tibial nerve to the bottom of the foot and the calcaneal nerve to the skin of the heel are compressed, you have decreased sensation. The study you're talking about, the group in the Philadelphia College of Podiatry used the pressure-specified sensory device, and it was something like half of their patients who came in with, quote, pain in their heel had abnormal sensation in their heel, and another 25% had abnormal sensation in their big toe and their heel combined, which tells you that the people presenting may have problems with the nerve, maybe related to swelling around the inflamed fascia. But as you said, we no longer think there's really inflammation of the fascia. And it may be that the cortisone injections that are given to try to help the plantar fascia calm down the swelling around the nerves that are stuck in these tight fascial places. But it's very important to distinguish between the compressed nerve, which would be the calcaneal nerve. And as you alluded to, there's a lot of anatomy variations. And ultrasound has been a good way out of this. I don't know, maybe you want to mention your cutoff numbers for whether they do or don't have plantar fasciitis by the thickness of the plantar fascia.
Yeah, so it depends what region, but and I can put this in the show notes, but basically traditionally in the literature, they're looking at where the fascia just anterior to where it is with relationship to the calcaneus. That would be what we call zone B. Normal from that would be usually 4 millimeters or less. But what's also important is the signal intensity, because we know that as the fascia degenerates, it becomes hypoechoic because you get this mucoid deposition in there. And I think that's really where they've identified a lot of the nociceptive molecules, why something that you inject may help, even though it's not because it's an inflammatory process. But long story short is that you have to look at both the signal intensity, the quality of the tissue, as well as the thickness of the tissue. There's some technology coming down the line that I think is going to be really great with sonography, and that's elastography. So some of these newer machines can actually put the transducer on, and it can measure the strain of that particular tissue. And so empirically, you could think that if you have a degenerated tissue that, say hello to Luann for me.
Hey.
Hey, Luann. But anyhow, the elastography is going to be able to give us a little bit of insight, especially after you do something from a regenerative standpoint. Does that tissue firm up and become normal density? So I guess that's a little tangential from where we're going. But to get back to the medial calcaneal nerve, it was very apparent, after I started working with you and you're starting to show me this whole different universe, that if I'm looking at a plantar fascia and it's not very sick, and then you marry that up with the history of that present illness, like you talked about, there's no post-static dyskinesia, but their pain gets worse throughout the day rather than better after a few steps, or their orthotic exacerbates their problem rather than helps their problem. They would often have what we would call a multiple etiology heel pain syndrome, or MEPS for short. So that's a very long-winded answer to come back to what you're saying about the quality of the fascia and how you can determine it. But more importantly, I think it takes off. Okay, if it's not a plantar fascia that looks sick, then we have to start thinking about something else. And that something else, more often than not, is medial calcaneal nerve.
So I'll show you in the hand. We talked about the carpal tunnel. Well, this part of the hand, the thenar eminence, is analogous to the heel. And we know that the median nerve, similar to the tibial nerve, gives off a medial palmar cutaneous branch, which innervates this. And we've described a tunnel for the medial palmar cutaneous nerve. And it made sense, therefore, for there to be a similar tunnel for the medial calcaneal nerve. And that's, in fact, what we showed. And one of the biggest problems in teaching foot and ankle surgeons was by your friend in Houston, Texas, whose famous phrase is that the nerve causing this problem is the first branch of the lateral plantar nerve, Dr. Baxter. And I got to read the nerve chapter when his book was redone, and I took Baxter's nerve out of Baxter's book, and Lou Schode, who was the overall editor, wrote an addendum to my chapter and put Baxter's nerve back into the book. But Baxter's nerve is a nerve to the periosteum from which the plantar fascia is originating. And if we go back to the arm, famous tennis elbow, you get multiple little tears in the periosteum that gives origin to the tendons that help you do your backhand. And the orthopedic surgeons would only focus on contractures in the tendon. They would actually cut all the extensor tendons from the bone and let it slide. Some of them removed the lateral humeral epicondyle. And it became clear to me that the pain was due to small neuromas from where the periosteum kept being torn. If you apply that to the medial calcaneal tubercle, there has to be a nerve going to the periosteum. And if the plantar fascia keeps being stretched and tearing the periosteum there, that pain message is going in a little branch that ultimately does become part of the lateral plantar nerve. But the medial calcaneal nerve goes to skin. And then following the lateral plantar nerve down, there may be other branches that really are going to the skin. And the final branch, the periosteal branch that Baxter calls his nerve, may be the second or third branch. It's almost never the first branch of the lateral plantar nerve. And so Baxter's operation, which someone has described to me as putting a hand grenade in somewhere, he actually winds up removing the medial calcaneal tubercle. And he says he's decompressing this nerve, but he's really dividing the nerve, which is similar to my saying we denervate. So for tennis elbow, we found the nerve that goes to the lateral humeral epicondyle. We disconnected. Tennis elbow pain is gone. They can use their tennis racket in 2 or 3 weeks, not 3 or 4 months. Mm-hmm. And the same concept may be related to what he's doing down there, is he's actually denervating the origin of the medial plantar fascia.
Yeah, if you look at his original study, it's pretty hard. I mean, from an academic standpoint, there's not a single arm. I mean, when you're going in and you're cutting the plantar fascia and you're cutting out the spur and you're doing all of this work in there, I think that's a great description. The hand grenade going off in that area. I mean, why are they getting better? And some of that argument could be, when you talk about plantar fasciopathy, people say, well, you have to remove the spur. And, we know that's just blatantly false. And the spur is actually a compensatory mechanism by the human body to increase area so that the shearing force is less. But long story short, they got better, not because the spur was taken out, but it was because they had to cut the plantar fascia to get the spur out.
All of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
This episode is sponsored by Savant Sellers, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantsellers.com. That is CEVANT sellers.com. Spelunk15.
Yeah. And
if you want to end with a story almost nobody knows, but it includes Texas and a famous baseball player.
Sure. Let's go ahead. I have a feeling I know, but go ahead.
I was giving a lecture at some university in Texas on diabetic neuropathy, and there was a white-haired orthopedic surgeon sitting in the front row. And when I finished, he said, well, that's all well and good, but why should any of us believe anything you say, because Johns Hopkins ruined Joe DiMaggio's baseball career? And I said, what do you mean? I've never, ever heard of that. He said, oh, you can look in any of his autobiographies. It shows him on a pair of crutches in a camel hair coat leaving the front of the Johns Hopkins hospital. And after they operated on him there for his heel pain, he never, ever played baseball again.
They missed part of that story.
I came home from that meeting and had one of our residents go down into the bowels of the Johns Hopkins Hospital and exhume the actual chart for Joe DiMaggio. And what happened was he had heel pain, and the most famous sports medicine doctor in New York did just what you said. He removed his medial calcaneal tubercle, and the incision was a horseshoe-shaped incision. He raised a distally based flap of its heel, and the entire flap died.
Yeah. And you know what the name of that incision? It's called a Griffith's incision.
Oh, well,
it's great. Yeah. I mean, but go ahead. So
Joe DiMaggio came to Johns Hopkins to have his heel reconstructed. It had nothing to do with his heel pain. And he had a lot of dead tissue that had to be debrided. We won't talk about how it was debrided. And then the plastic surgery group skin grafted his heel, and he left. And he played baseball for 2 more years after he left Johns Hopkins Hospital. But I thought that was really a great story. So the person who attacked me was wrong in both the reason he came to Johns Hopkins and the fact that it ended his baseball career. He still had 2 more years.
Yes, I've actually looked at those records with you, and it's a pity that we couldn't, get that in the literature from a case study, because and incredibly enough, there are still some surgeons doing that procedure today where they flap the whole bottom of the heel off to get to the bottom of this calcaneus, and you think, wow, they've just destroyed one of the most intricate biomechanical mechanisms that we have, this infracalcaneal fat pad is extraordinary for what it does. I mean, it's literally the piece of tissue that keeps your brain from rattling around in your cranial vault like a golf ball in a mayo jar because of all of the miraculous things it does. And then here you go. You cut those septa and flap that heel down. It's amazing. So let's go to Baxter 1 second, because I think Baxter will give me a segue to this next little topic that I want to talk about. And that is this poor Dutch gentleman named Reg Holt published all of Baxter's nerve stuff way back. I think it was 39. And then even another podiatrist published some stuff identifying this nerve, I think in 1980, 81. And then suddenly it becomes Baxter's nerve. I feel like Baxter kind of hijacked stuff from Reg Holt. And I think the same thing happened in Morton's with Civanini. So you have this anatomist in Italy who identified the Morton's entrapment. I don't even like to say the other word, but identified this entrapment, but then comes along, he gets no credit for it, even though he's written 10 years earlier. But that happens in medicine all the time. And so I guess that's a great way. Let's talk about Morton's entrapment a little bit.
So part of the same thing happened with the innervation of joints. It turns out that a man named Nicholas Rudinger in 1857 in Munich, and this is part, again, of the story of the Prosector, which does begin with this woman being born in the city of Munich in Germany. Rudinger, for his PhD thesis, which was entitled Nerves to the Joints of the Human Body, he'd identified all these things, but it remained as a PhD thesis hidden in the archives of the library. And it wasn't until a doctor from Germany in 1966 or so, August Wilhelm, found this and began doing some wrist innervations, again, published in German. So the part of the answer to what you said is the work was published in other countries in different languages. It was way before the internet, and stuff just simply wasn't known. I mean, Tenel described his sign in 1918 in France, and Paul Hoffman described it in 1918 in German, and the French literature was more easily accessible, and the Germans had just lost World War I, and people didn't want to translate the German papers, and so people just didn't know that Paul Hoffman had made the same discoveries as Jules Tenel. And when the first patient came to me with what was termed Morton's neuroma, I had no idea what it really was. And when you look up Morton's paper, which is from something like 1874, you could write, and that's what's fun about looking at the old literature. You could write all these things. And he describes this lady who would have to pull off her shoe because she had horrible pain in her fourth toe. But she knew she was injured stepping on a stone, hiking in the Alps. And he describes which mountain, how she walked down one valley, crossed up another one. He lays out the geography of her trip, things we can't do at all today. And he thought her problem was in her joint. And he actually called it metatarsalgia, meaning joint pain. And his treatment was to remove her fourth toe, during which he also removed her nerves. And she was relieved of her pain. And over the years, the name for what Morton described variously was termed different things. You and I have a paper with a big list of all these things.
Right.
But it became called a neuroma. Once you called it a neuroma, the treatment of a neuroma is to remove the nerve.
Yeah.
And so then, as you know, once you remove a nerve, you create a true neuroma. Originally, there was just a nerve compression. And so we began decompressing this nerve instead of removing it. And now, do you happen to know, isn't it something like 50,000 nerves are sacrificed each year for Morton's neuroma in America? Some large number like that.
It's a large number. I know that there's a hell of a lot of them that end up in chronic pain and end up in tertiary clinics. But, it's, I guess the definitive way of getting a neuroma is to just cut the Morton's entrapment out. Then you truly have a recurrent Morton's neuroma. There was a paper you published on recurrent Morton's neuroma. And now I can use the word neuroma because it truly is a neuroma once they've played with it. What was the percentage? There was a very, very high correlation with these folks that had failed Morton surgery. And then they had it was a very large percentage demonstrated true tarsal tunnel entrapment. Yeah.
So those are two different papers. And quite early on in, I think you said 1984 or something, I was sent a runner from the University of Maryland who had a Morton's neuroma removed between his third and fourth toes. And he had pain in the bottom of his foot and he couldn't run. And no one wanted to operate on the bottom of his foot because he was a runner, which we know we can operate safely on the bottom of a foot of a runner if we're careful and we close it properly, Right. And I had worked out earlier with Dr. McKinnon around 1982 that if you took the live end of a nerve after removing the neuroma and buried the live end of the nerve in a muscle in a quiet place, you could prevent these recurrent painful neuromas. And we started doing that everywhere in the body. But in the bottom of the foot, no matter where you tried to move this nerve, you would still be putting pressure on the plantar aspect of the foot, certainly the distal part. And it occurred to me the only place you could put the nerve where there would be no pressure was in the arch. And so I designed an operation on this runner where I cut down from the heel through the non-weight bearing part of his foot and found the nerves and implanted them into the fibrous tissue in his arch, where they then would be covered by two muscle layers and sewed up. And he actually went back and ran a 4-minute mile, and he gave me his trophy when he ran a 4-minute mile. And that was my first experience with this in a difficult, challenging situation. And technically, it's a hard operation to do because when you go through the arch, you come down to the flexor brevis muscle, you have to go through the medial side, then through the lateral side, because especially if this nerve is formed in the third and fourth interspace, it may have a contribution from both the medial and lateral plantar nerves. Right. So you have to pull the muscle laterally, pull it medially, find the main medial and lateral plantar nerve, trunks as it were, go distally, do an intraneural dissection to get the distal nerves, divide the correct ones, and then implant those on the arch of the foot. And that operation withstood the test of time. And as time went by, we had a resident named Sean Wolford, who's actually now an associate professor at the University of Arizona, but in Phoenix. And when he was a Hopkins plastic surgery resident, he reviewed a group of my patients. And this double crush concept, which comes back to diabetes, that a nerve in trouble in one place by compression decreases exoplasmic flow, and it makes the nerve farther downstream more susceptible to compression. So as you already said, if you have tarsal tunnel syndrome, meaning pressure on the nerve in the ankle medially, and that nerve farther distally becomes a common plantar digital nerve and can be compressed beneath the intermetatarsal ligament, then you have a nerve that has compression at two sites. And so some of the people who did not get better, or some of the people who developed true neuromas after the nerve resection distally, might have had their symptoms due to tarsal tunnel pressure, especially if they had more than one toe involved. And so we began to examine our patients with failed Morton's neuroma surgery, which is a true neuroma, seeing if they had a Tinel sign. And it turned out that we had 12 patients in the study. 7 of them had tarsal tunnel syndrome, which is a lot. You know, it's like three-quarters of your patients who are going to come to you with failed distal Morton's neuroma surgery have a proximal compression. And what it means for you practically is even if you successfully fix the neuroma pain, they're still going to have symptoms from the tarsal tunnel compression, and they will present to you as a failed procedure. So you need to look for that to know to decompress the tarsal tunnel at the same time you treat the distal neuroma.
Yeah. I don't know if I told you this or not, but you and I didn't actually meet each other until it was around the year 2000, I believe. But when I was working on the development of one of our endoscopic procedures for Morton's decompression, it was actually one of your articles that you had written that was really very seminal for me, because you made the very insightful comment that Morton's neuroma is the only peripheral nerve entrapment in the human body that's being treated primarily by resection. And so I want to thank you for publishing that, because that really gave me enough to go say, listen, we don't need to be cutting these out. And the other thing that motivated me to really focus on decompression was the fact that we would go in and based on symptoms, you would think this neuroma is going to be so big, and I use air quotations around the word neuroma, okay, that I'm going to need to send this not only to pathology, but to the taxidermist when I get finished with this case, because this bad boy is so painful, it's going to go up on the wall right there next to all of the other trophies. And then you get in there and it's a pristine, normal, nice diameter nerve that is just simply pinched. And then now you're cutting it out. And there's no one that knows more than you about when you take a nerve that is just really needing a neurolysis or a decompression and you cut it out. Now you've gone into a neighborhood that is a little bit rougher. And, when you denervate something, central nervous system doesn't like that as much as it tolerates neurolysis decompression. You can pretty much feel pretty good about, neurolysis and decompression, but you don't want to cut a nerve out unless you absolutely have to. What's your thought processes on some of these neurodestructive procedures for a nerve that is really just compressed? I mean, cryoablation, ethanol injections. What's your take on that?
Well, as you know all too well, okay, how many podiatrists are there in America?
24,000 plus, maybe?
Yeah. And so the majority of podiatrists don't operate as what we would call surgery. And for these doctors, they try to help their patients with Morton's neuroma pain by injecting steroids, which is fine. That's what we do for compression here. But then if people don't get better, they really should refer them somewhere else. But for the non-operating foot and ankle physicians, they then went to trying to kill the nerve with alcohol. Sometimes the alcohol kills the skin. And I've been to foot and ankle meetings where an entire hour is given over to someone describing how they inject alcohol into this space, how they prepare the alcohol, the size needle. It's a huge, big thing. But the point is, we don't want to kill the nerve. We want to decompress the nerve. And I think as we move into more modern times today, perhaps fewer and fewer non-operating foot and ankle physicians will use alcohol, but may still use steroid and then refer them to someone else. The cryo stuff is a totally different concept.
So
I'll just explain that to you because
go ahead.
It turns out, related to cancer and primarily prostate cancer, the cryoprobe was invented. And the idea was if you cool tissue down enough, like below 120 degrees, like to minus 240, tissue dies. It freezes and dies. And it was developed as a way to kill cancer cells. And there's several papers on this, and it is true. If you cool a nerve down only to about minus 20 degrees centigrade, the nerve stops working, the axon degenerates, but you haven't destroyed the nerve tube. And the nerve will regenerate exactly back to where it was. And so for pain, not to recover sensation, but for pain, it shouldn't be called cryoablation because you're not trying to kill the nerve. If you kill the nerve, you will get another true neuroma there, the same as if you've cut it out. But what should be called cryoanalgesia, the nerve will stop sending pain messages. And in some number of people, you may have to repeat it 3 or 4 times, but the nerve then will just stop. It stops regenerating or whatever, but the pain will stop in some people. And so I know that has been applied to the common plantar digital nerve, but once you know the mechanism is compression, just telling the nerve to chill shouldn't really be the solution. Telling the nerve that to give it more space in which to live should really be the correct approach.
Well, I know that there was a veterinary study by two guys, Schneider and Mayhew, that looked at cryoablation in, I forget what nerve in the extremity of a horse, and they had about a 40% incidence of development of a neuroma incontinuity from their cryo, which
they killed it too. It was too cold.
Yeah. So that's kind of an interesting thing. They're trying to get one type of a nerve injury, right? A Sunderland 3 or 4, and they end up with a neuroma incontinuity, which is a horrible pain generator in and of itself.
Yeah. We're just finishing a sort of a review paper on cryoanalgesia to send to one of the plastic surgery journals. And if you want, I'll send it to you because it has the references to the histopathology of using the correct temperature and causing, neuropraxia or an axonotmesis. And you can use that if you want to write papers about it instead of what they did with the horses.
Yeah, I'd like to see that. I appreciate that. Well, we talked a little bit at the beginning about the Prosector, and what's the next book now that you've become a novelist?
Well, I would encourage the people listening to this to get the book. I'm not saving my retirement by selling copies of the book, but I think this book is a very inspiring book, especially for women going into a surgical field. It's an exciting book to read, to learn about peripheral nerve research and the prejudices against it. And I just think it would be a fun book. You can say that Dellon is the new Michael Crichton. And now that I'm retired, we're traveling around the world teaching into different meetings. People like yourself have developed podcasts to help educate the public. I think one of the goals should be, and we're working on this, to come up with curriculum changes so medical students, even in the first year of anatomy, can learn about anatomic variations. And when they get in the second year and learn physical diagnosis, they learn the correct way to tap and not use a reflex hammer. And when they learn about disease and they interview a diabetic, besides asking, do you have any trouble with your vision, checking kidney function, they should examine for nerve compressions in every diabetic's foot. That should be taught in medical school. And then when they become endocrinologists or internists, they'll know to look and think about doing this.
Right. Well, I've got a great story. One of my MAs, and she was actually in a class that I teach up at Kennesaw State, Bailey Boyd, and she's just a rock star academically. And she started medical school this year down at Mercer. And I'd get a text from her occasionally from her anatomy lab sessions, and she'd say, we're seeing these nerves that are swollen. And I went and I looked, and they're the ones that are swollen are the diabetics. And she wanted to, have some verification from me. Is she seeing what she really thinks she's seeing? And because she had spent a lot of time with us in the clinic. And I thought that was really great because regardless of what specialty she ends up in, she now has this fundamental nerve understanding that is not in the normal day-to-day curricula. And so I think that's a really great approach, is that you have to get in there while those minds are still young and receptive and they haven't been, tainted by all of the dogma. That's the time to get that in. So,
and I have to say, on a really positive note to end, half of our plastic surgery residents at Hopkins are interested in peripheral nerves and are either going on to do hand fellowships, which are very nerve oriented, or taking now available peripheral nerve fellowships, such as you have a fellowship with you. Now, this is a huge change from people going into plastic surgery primarily to do cosmetic surgery, but understanding how many people can be helped. And in this lecture that I give now, and I will be giving, we talk about how many people with migraine headaches can be helped by nerve decompressions. the 50,000 new patients a year with groin pain, some part of the Morton's Nervana group. The 800,000 knee replacements were done last year.
Yes.
And even 5%, even if they're 95% effective, that's 4,000 or 5,000 people every year with knee pain that we can help. And then 40,000 or so diabetics in America, 40 million, 20 million of which have a neuropathy, half of which will have a nerve compression in their lower extremity. So we don't have the surgical manpower available to help the people in this wide spectrum of nerves that we could help. So it's an exciting time for peripheral nerve interest.
Well, I really can't thank you enough for everything that you've done for me personally with what you've taught me and showed me over the last 20 plus years. And it's been a tremendous ripple effect. And, the fact is that, there's a whole subspecialty now, the Association of Extremity Nerve Surgeons, that has developed because of your work. And those people are training more people like we're training. And, that's the way. So from a ripple effect standpoint, I have to take my hat off to you because, the amount of people that you've improved their lives is far greater than the people that you've just personally operated on. It's, so thank you for all of that. And thanks so much for sharing this with us today.
Yeah. And I'm glad you mentioned the Association of Extremity Nerve Surgeons. It's AENS.US. And I've recently referred a plastic surgeon from Mexico City to take the fundamental workshop in November. It's a great way for people who've been out there in the world who would like to get back into the nerve universe to learn lower extremity nerve decompressions. The course is given every November somewhere. You can look on their website. And if you get through that course, then you can take the Nerve and Lobster advanced course given in Maine. And that group is doing a wonderful job in terms of educating others.
Yes, thanks so much. Lee, thank you. And I hope we can be in the same room drinking some wine one of these days.
Yeah.
So,
thank you. You're doing a great job.
All right. Have a great weekend, and I'll talk to you soon.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.